Anyway, I just want to say thank you to Laura Bird, my nurse practitioner, for helping me with the slides. I am not the most computer facile. In fact, I'm probably the least computer facile person there is in the room. So she really was instrumental in helping with this talk. And so anyway, I just wanted to give you a kind of a brief rundown of electrophysiology. Has anybody ever even heard of electrophysiology before? Couple of hands? Okay. So electrophysiology is a subspecialty of cardiology, and we go through the cardiology fellowship, and then there's an additional fellowship in what's called electrophysiology, which is the study of heart rhythms. And we deal with fast heartbeats, slow heartbeats, dizzy spells, blackouts, all sorts of fun stuff. So if you have to see us, it's usually not a great day, but sometimes it is a good day. So I just want to start out with a little bit of anatomy of how the heart works and how it looks. This is a typical heart. Normally the heart's about the size of your fist. Some people have a bigger heart. The way the heart works is it gets blood from the legs through the inferior vena cava here, through the superior vena cava here. This is blue blood, that's why it's colored blue, deoxygenated blood. That blood comes into the right atrium. It gets pumped across a valve called the tricuspid valve and goes into the right ventricle right here. The purpose of valves is to keep blood moving in one direction. It's like an engine, really. From the right ventricle, blood gets pumped out across another valve into the lungs. This is called the pulmonic valve. In the lungs, there's a left lung here, right lung's over here. The lungs are where you breathe in your oxygen, get rid of carbon dioxide. Once blood has oxygen, it comes back into the left atrium through four little veins called pulmonary veins. Here's two hiding over here. This is a left superior and inferior pulmonary vein. This is a left atrium. The right superior pulmonary vein and right inferior are behind that, and we can't really see it. The atrium then contracts, sending blood across to the left ventricle, and this is the main pump. If somebody says you've had a heart attack or a weak heart or a strong heart, that's what they're talking about, is the left ventricle. You'll see that the wall muscles are thicker on the left ventricle than the right ventricle. And if somebody has high blood pressure, what that does is it makes the walls even thicker. And that's called hypertrophy. So from the left ventricle, blood is pumped out of the heart through the aortic valve. It comes up here, and this is the aorta. That sends blood to the right arm over here, up to the brain through the carotid arteries here, and this goes to the left arm over there. So, and then that aorta comes down behind the heart, gives up blood to your liver, spleen, kidneys, and divides into your legs, and that's a circulation. That's represented by an ECG. If somebody has done an ECG, the P wave, the first part of it, is the atrial contractility. The QRS complex, which is the big spike, is the ventricular electrical activation. And then the way the heart repolarizes or relaxes electrically is here, from the QRS complex to the T wave. So when you do an ECG, this is what we see. If somebody's had a heart attack, we'll see changes here. And there's all sorts of different things on electrocardiogram. So this is kind of an introduction, and we're going to get into this a little bit more detail. This is me. I work at Inland Cardiology up on the Goethals building. It's northeast of KADLEC Regional Medical Center. My clinic days are Tuesday, Thursdays, and Fridays. And I work in the laboratory on the other days of the week, Mondays and Wednesdays. So when would somebody need to see an electrophysiologist? Has anybody here ever seen an electrophysiologist? A few people, probably. I'm recognizing somebody that I just saw. So there's a whole list of things that could bring somebody to see me. Talk into the mic, please. Oh, okay. Sorry about that. Thank you. And by the way, if anybody has any questions or is outraged by anything I say, you can just jump up and say it, because that's very helpful. And I'm like President Trump. Come on. Anyway, we're ready to roll, and if you can't hear me, let me know. So if anybody has dizzy spells, blackouts, palpitations. Palpitations can be different to different people. Some people say a palpitation is an extra heartbeat. Some people say it's a racing heartbeat. But any type of extra heartbeat or irregular heartbeat You really shouldn't even feel your heart beating if it's beating normally. How many of you have never felt your heart beating? So most of you have had some irregular heartbeats over your life, but there's a handful that haven't ever felt it. I've never felt my heart beating, thank goodness. So it's normal not to feel your heart beating. You could have skipped beats, pauses, unexplained falls. One of the reasons for our visits, the most common reason somebody comes in the emergency room is blackouts. So if you black out, you might fall. I have patients swear that they didn't pass out, but then they have raccoon eyes. You wonder, well, how did that happen? But sometimes you don't even know you passed out if you fall hard enough and quick enough. Any type of an arrhythmia is a fast heartbeat or a slow heartbeat. Heart failure. Heart failure is defined as the heart not beating properly. If you've got a weak muscle, sometimes the things we can do can make the muscle stronger, be it medicines or devices. Anticoagulation, that's a blood thinner. The most common reason for strokes is atrial fibrillation, one of the things we'll be talking about today, and the way to prevent that is to be on a blood thinner. Pacemakers are devices with a lithium iodide battery and a computer that make the heart go faster. Implantable cardioverter defibrillators are devices that can either pace the heart if it goes too slow, or if it goes really fast, it paces it out of that or charges up and delivers an electric shock. That's a fun one. Cardiac resynchronization therapy systems are if somebody's muscle is weak and the conduction is slow, we can put these devices in. Sometimes this means 3 leads into the heart, and then we can pace and resynchronize the heart and make patients feel better. So what do we do if somebody has a bad rhythm? Sometimes we can burn it out or freeze it out. Cryoablation is where we freeze it, and radiofrequency catheter ablation is when we burn it out. We can do arrhythmias called atrial fibrillation, atrial flutter, SVT, PVCs, and VT. T is a tachycardia. Tachycardia is any fast heartbeat. So it's called tachycardia. Tachy means fast, cardia means heart. SVT means it's above the ventricle, supraventricular. And flutter is usually a counterclockwise circuit in the right atrium, but it can be in the left atrium too. So a pacemaker. How many of you have a pacemaker in this room? Anybody? Quite a few people. So a pacemaker is really neat. Prior to pacemakers, people would basically walk around with heart rates of 30 and feel horrible. With a pacemaker, this is the device. You can see the circuitry inside. We put 2 leads in some pacemakers, 3 in others, and 1 in another. But you'll see this lead here is a schematic. This is a subclavian vein that we get into with a needle, and we thread a wire through that down into the bottom chamber called the ventricle and into the top chamber called the atrium. And you see it on the x-ray. This lead right here is the atrium, and here's the lead that's in the ventricle. And this is the pacemaker itself. These are the lungs, the black things, and this is the heart, the white thing. This is the diaphragm. So rarely, if somebody has a twitch, if they've got what's called a biventricular device, it'll be pacing the diaphragm. It's close enough. This lead is not even close, but the phrenic nerve, which paces the diaphragm, comes here. And sometimes we can be, twitching the diaphragm. They're going like this. They get irritated in a hurry. So we always test for that. Indications for pacing. Why would we put a pacemaker in somebody? The most common reason for a pacemaker is what we call sinus bradycardia, where the sinus node goes too slowly. The sinus node is a pacemaker that God gave you. It normally fires anywhere from 50 to 80 beats per minute when you're at rest. It can go up to 220 minus your age as a maximum predicted heart rate. As people age, it's just like any battery. It starts to slow down and wear out a little bit. Chronotropic incompetence means that when you're on an exercise program, you can't get the heart rate up. You might not have a slow heartbeat at rest, but you just can't get it up. Second degree heart block is you've got a problem with the AV node, with a junction box in the heart. And the AV node we'll talk about a little bit later, I think. But the most important thing for a pacemaker is symptoms. You can have a heart rate of 30, or you can have pauses of 3 to 8 seconds, and if you're not symptomatic, we don't really put a pacemaker in. So the history is really important in medicine, and that's why we spend a lot of time talking to patients before we do any procedures. We say, well, when is it slowing down? Well, if it's slowing down at night, what do you think we might be worrying about if your heart rate slows down at night? Stopping. What else? What might cause it to slow down or stop at night? Any ideas?
Drug interaction.
Possible drug interaction. If you're on any beta blockers, that might slow your heart rate down at night. What else?
Apnea.
Apnea. That's huge. And that's one of the least diagnosed problems, probably in our community or in the United States, is undiagnosed sleep apnea. There are two different types of sleep apnea. One is where you snore like a freight train. Like my wife will say, I snore like a freight train. But some people have central sleep apnea where you don't snore, but you just don't breathe enough. And either one of these will lead to low oxygen, and then that can cause the heart to become erratic or to slow down, or over the long term, it can cause what we call pulmonary hypertension. So if your doctor hasn't thought about that, if you're snoring or if you're taking naps during the day, if you sleep and wake up a lot, you might be having sleep apnea that should be diagnosed. So that's just one thing to think about. Third degree AV block means that you've got a real problem where there's no conduction whatsoever between the top chamber and the bottom chamber. And the effective rate of the ventricles is about 30 beats per minute. The sinus node, I said, was 50 to 80, and then the AV node, which is below that, is about 50 or 50 to 45 beats per minute. So if your heart rate, if you block further and further down, you go slower and slower. Some people have what we call asystole, where they just go flatline, and then they usually pass out if it's more than a few seconds. Sometimes we burn out the junction box, called the AV node, if somebody's going really fast and we can't control them with medicines, and then we need to put a pacemaker in so they don't go too slowly. Sometimes people have valve surgeries, and after valve surgeries, sometimes there's a need for a pacemaker because of the way the valve is cut out, or some people with aortic stenosis where the aortic valve is calcified have calcification in the conduction system that also causes the heart to slow down. So sometimes we put in two leads. That would be a dual chamber pacemaker like we saw in the chest x-ray. Sometimes we put in an atrial lead only. And those are for people with sinus node dysfunction with a normal conduction system down below that. Or if they just can't exercise like they want to, they just can't get the heart rate as fast as they want to. If somebody's got atrial fibrillation where the top chamber is going 300 to 500 beats per minute and the bottom is what's slow, then we just put a single lead in the ventricle. So if there's problem with the lower part of the conduction system, we always put in two leads, one in the top, one in the bottom. Now, resynchronization therapy is where we actually resynchronize the heart. If somebody's got a bundle branch block, that means the bottom part of the conduction on the left or the right is slower than the other side. And then we would put in three leads. For this particular case, you see that we have a lead up here. This is actually in the left ventricle outside the heart. We thread it through a vein. This is the hardest vein. This is the hardest lead to put in by far. It's pretty easy to put them in the atrium and the right ventricle. But to thread this one in, there's a vein that opens up here, and we thread it through that vein on the outside of the heart and right over here. Now you see if this is a little bit further down, it could potentially pace this diaphragm over here, and then they might get hiccups. So if you have a biventricular device and you're hiccuping, it's probably because the lead is too close here. And sometimes we can get away with that by pacing at a lower output. You see, this is a bigger device. This is actually what's called an implantable defibrillator. This has a shocking electrode. This lead right here is a shocking electrode, which is bigger than a normal pacemaker lead. And this is a typical situation where if somebody goes too fast, this device can actually, it has a capacitor and a battery. It can charge this and deliver a shock from this coil to stop the heart for milliseconds. And it shocks between here and the can, and then resets. One of the neatest videos I've seen in a long time, well, I trained in Baltimore, and they had that's where the defibrillator was really created. And they had a video of a dog, and here's the little dog traveling down the road, and then they put the dog into ventricular fibrillation, which is a fast rhythm of about 300 to 400 beats per minute. And the dog's traveling along and just flops over on his side. And then the device automatically charged up, shocked him out of it. He gets up, wags his tail, and trots right off. Didn't know anything happened. And that's what we do now with these implantable defibrillators. Prior to the advent of these, people would have to have a cardiac arrest, end up in the emergency room if they were lucky enough to survive. About 10% of people with an out-of-hospital cardiac arrest survive, and that's in the best communities. Actually, Seattle is one of the quickest communities. They've got lots of different defibrillators in lots of different areas, and so the out-of-hospital survival is about as high as any place in the country. But these devices are really nice. These devices are very nice. They don't last as long as a pacemaker. They're actually a pacemaker, but they last about half as long just because they do more things. With the capacitor, they can also save your life if it goes too fast. So the indications for a CRT defibrillator or pacemaker are an ejection fraction less than 35%. Ejection fraction, does anybody know what an ejection fraction is? Here's a couple of hands. An ejection fraction is how much blood is ejected with each heartbeat. And a normal ejection fraction is about 55 to 65%. And if your ejection fraction is less than 35%, you'd be a candidate for one of these CRT devices or an implantable defibrillator. To be a candidate for a CRT, you have to have conduction that's slow, so it's kind of a wide QRS duration. Some people, if we know that you're going to be pacing a lot, if you've got any heart function that's not normal, we would go ahead and put a CRT device in just to prevent the heart from getting weak.
How long do those last?
So the CRT defibrillator will last anywhere from 6 to 7 years, maybe 8 years if you're lucky. A typical pacemaker will last anywhere from 10 to 12 years, depending on how much you're using it, sometimes 8 to 12. And it depends a lot on the output. It's just like anything. If we pace at a high output, it's not going to last as long as if what we call pacing thresholds are low, so we can pace at a lower output. So it's usually 6 to 8 years for a CRT pacemaker defibrillator. Any other questions so far?
Can you externally determine what the battery life is if it's getting close to?
Right. So the question was, can we externally determine what the battery life is, and how do we know when it's getting close to need to be changed out? For somebody with a pacemaker, we will see them every 6 months or at least every year in the clinic. Now most devices have remote monitoring systems where we can follow people anywhere in the world over the internet. And back in the 1980s, Vice President Cheney had a device. So I would get alerted intermittently when he would come to Colorado Springs. I was the one who would take care of him if there was an emergency. I never had to do anything, but they had contingent plans for that. And there was actually a movie that looked at actually taking a person of high value and reprogram it over the internet. You cannot reprogram these things, but we can download the information over the internet. But reprogramming was what they claimed was happening in this. And I'm telling you, the authorities in Washington were paranoid about somebody being able to do this with him. He eventually got a heart transplant, so he didn't have to worry about it, huh? So how about implantable cardioverter defibrillators? Who is a candidate for those? Now, cardiomyopathy is just a muscle problem, a heart muscle problem where the heart muscle doesn't work properly. There can be hypertrophic cardiomyopathies where the heart strength is too strong, and it's a very thick ventricle, and those patients have a family history of sudden death, and you can just follow it down the family history. If somebody's had a heart attack, that predisposes anybody to bad rhythm problems, especially if the heart muscle is weak. But where the normal heart interfaces with the infarcted heart by definition has a scar. And where the scar is next to the normal tissue can cause a reentrant short circuit. So anytime somebody's had a heart attack, we worry a little bit, especially if their heart muscle is weak. Now, we can't just put a defibrillator in everybody. In the old days, and old days were probably 20 years ago, we would have to have somebody have a cardiac arrest before they would be a candidate for a defibrillator. Now we've found out that there are higher risk patients. So if the overall pump function is weak, that puts you into a high risk category. If the ejection fraction is less than 35%. Or if you've got any family history of sudden death and you've got problems with the way the heart relaxes electrically, that can cause rhythm problems. So what we normally do is put somebody who's had a heart attack on different medicines. A beta blocker, things like metoprolol, carvedilol, bisoprolol, and what's called an ACE inhibitor or angiotensin receptor blockers, or spironolactone, which is an aldosterone antagonist. Once we put them on those, we have to wait. If they've had a heart attack, we wait for 90 days if they've had a stent or any type of bypass before we can actually reevaluate them and make sure if they qualify. Because these are very expensive devices. An implantable defibrillator, the cost alone is probably $30,000, but by the time you get the bill from the hospital, it's probably more like $100,000 just for that. These are very expensive things. So if somebody hasn't had a heart attack, but they've had a virus that affected the heart, or maybe they've had other issues that we don't know what caused the heart. Alcohol sometimes, and high-dose alcohol can affect the heart muscle too. So in that situation, we like to have people get rid of the potential things that are causing problems. Once they've been evaluated, then they're referred, and if the ejection fraction stays less than 35%, they're a candidate for what's called a primary prevention defibrillator to hopefully prevent somebody from dying. And these things are really great. It takes about an hour to put them in for a single chamber. It takes about an hour to put it in if it's a dual chamber. It doesn't take much longer. And for a CRT, it can take 2 to 3 hours, depending on how hard it is to put the lead into the vein. But they usually go home the same day. And I've had a patient who got one on one day, and a week later he got his first shock. So it might have just saved his life. I've had 50% of the patients who never get a shock. So, but if it's there, if you need it, it's there, and it works pretty slick. So now they've also got subcutaneous defibrillators, so we don't even go in the heart, or don't even go in the heart with a lead. These are called subcutaneous defibrillators, and the box is actually on the outside of the lung, on the side here, and we tunnel a lead kind of underneath the sternum, underneath the breastbone, and the lead goes up here, and it's tunneled this way here. So we don't even have a lead in the heart. The best patients that work for these are young people who we don't want to fill up the veins with leads, because these leads aren't going to last a lifetime. Sometimes they last for 8 years, sometimes they last for 30 years. But if somebody's 10 years old and we're putting these things in, that it's going to fill up before long. So we put those things on the outside of the heart. They're not pacemakers. They're just defibrillators. Somebody on dialysis, if they're on dialysis, a lot of times they use up veins just trying to get access for dialysis so they can dialyze and take care of their kidney problems. So indications. If it's a single chamber, if they've got atrial fibrillation, dual chamber if they also need a pacemaker, or CRT device if their pump is weak and they've got conduction problems. So we talked about that. Arrhythmias. There's all sorts of different types of arrhythmias. I'm starting to get some blurred vision back here. Anybody have any questions so far? So we've got all sorts of different type of rhythms. How do we determine what they are? This sinoatrial node reentrant tachycardia looks a little bit like what we call sinus tachycardia. If you're running a race up a mountain, your heart rate's going to go normally 220 minus your age, unless you've got chronotropic incompetence. That would look like this, but these are just people who are sitting around listening to a lecture like this, and all of a sudden their heart takes off. So that's not good. Atrial tachycardia is any type of fast rhythm in the atrium. It could be left or right. I had a 16-year-old kid one day, he's one of the best swimmers in the country, who had an atrial tachycardia, didn't even know he was in it. But he came to our office and we did an ultrasound and his heart ejection fraction was 30%. So this is a 16-year-old elite athlete whose heart was terrible. And fortunately, we took care of the atrial tachycardia. It was in the left atrium. We burnt that out and his heart normalized. So I just wanted to introduce you to the concept of what we call tachycardia-mediated cardiomyopathy. That means if your heart's going fast, the muscle can get weak because it depletes the energy stores, and then the heart starts weakening. I've got a guy in the hospital right now I've got to go see right after this talk who came in with atrial fibrillation, didn't know it. He was at another hospital, and now his heart is 30 to 35%, and he doesn't even know that his muscle's weak, and he was about ready to fall off a cliff. He didn't even know that. So this is a scary thing. I would encourage everybody to just check your pulse every once in a while. Make sure you're still alive. I'm just kidding, obviously. There was a good, I think there was a commercial I saw on TV today about this thing that does the screenings for $150, and it takes an EKG, does an ultrasound. That actually, I think, is a great idea. The reason is it's very cheap and you do get some good information. But just if you feel your pulse, if you don't know how to feel it, it's on the thumb side of your wrist and you press hard, you should be able to feel your pulse. Just see if it's regular. If it's not regular, you're probably in atrial fibrillation. The problem with atrial fibrillation is it can lead to a stroke, even if you don't even know you're in atrial fibrillation.
What was that ultrasound thing again?
It's basically, they do screening to see if you've got an aneurysm in the abdominal aorta, to see if you've got any calcification in the carotid arteries. They do either a rhythm strip or an EKG to see if you're in atrial fibrillation. But your own doctor can do this, but your own doctor is probably going to charge you more, I would think. For $150, the lady on the commercial says, "That's the best $150 I ever spent." And I think that's probably true,
One of them's called Lifelines.
That's what it was.
Yeah.
That's what it was. Lifelines. And I think it is a reasonable thing because it's very reasonably priced. And so, atrial fibrillation. I just wanted to talk briefly about this. It can be paroxysmal, means it's lasting less than 24 hours, and then it resolves. Persistent means it's been there more than 7 days, and permanent means that we've made a decision not to treat you with either rhythm medicines to get you back into the normal rhythm, or to burn it out. We're just going to leave it in there, leave you in the atrial fibrillation. You say, well, why in the world would they leave me in atrial fibrillation? There was a good study called the AFFIRM study that actually looked at people for rate control versus rhythm control, and if they weren't symptomatic, if they didn't have any symptoms, the rate control did just as well as the rhythm control with probably less risks, less problems. So, atrial flutter can be typical. That means it's in the right atrium, counterclockwise circuit. Atypical means it's either a clockwise circuit or it's in the left atrium. Left atrial tachycardias are harder to deal with. Right atrial flutters, we can usually take care of within an hour to an hour and a half, and you're cured. Atrial fibrillation, if we're going to burn that out, it's usually a 3 to 4 hour procedure where we go in there under general anesthesia and burn around the pulmonary veins. But that's beyond the scope of this. We don't like to do an ablation unless you've failed at least 1 or 2 medicines, or unless you're very symptomatic. I wouldn't really consider this for somebody who's not symptomatic. Now, these are the patients I really like. The type of SVT, atrial ventricular nodal reentry tachycardia, is the most common type. This is when we do an EKG and we can't really see the difference between the atrium and the ventricle contractility on the EKG. But these patients will just go into it and out of it, just bam, all of a sudden they're into it. Sometimes bending over will cause this. I've had a lady that was probably in her 60s who had to quit gardening because every time she bent over, she'd go into the rapid rhythm, going 180, just feel terrible. So she gave up gardening. And that was one of the most, that was the coolest thing afterwards. When I saw her back after an ablation, she literally said, "Hallelujah, doctor." She was so happy. She was gardening again. We gave her life back. So the cool thing about being an electrophysiologist, a lot of times we can actually cure people. A lot of times in medicine we can't cure somebody, but in some of the things we have in electrophysiology we can actually cure, which is really gratifying. So how does this work? These are reentrant short circuits. So the sinus node is right here, up near the atrium. My pointer's weakening. Let's see. Right here is the sinus node. The AV node is here. The His-Purkinje system, which is the bottom part of the conduction, is here. The left bundle branch comes off here. The right bundle branch comes off here. Now, some people are born with 2 junction boxes, 2 AV nodes. About 30% of normal people are born with 2 junction boxes. And in the right milieu, if you will, too much caffeine, too much alcohol, too much adrenaline, sometimes just behaving themselves, they'll go into the rapid rhythm. And it's like a dog chasing a tail right over here. It can go 150 to 180 beats per minute. I always thought that was one of the coolest things when the dog chases tail. Uh-huh. Oh, sorry. So the other type of rhythm is somebody who's born with a bypass tract. Now, a bypass tract is an electrical muscle. It can be no bigger than a hair. It can be over on the left side. This is called the left lateral. It could be coming around this way. But it's an electrical fiber that can conduct backwards or down. And that can cause a short circuit also. These are actually the easiest ones to take care of, and they're actually pretty fun. I don't know if any of you have had a friend or has ever had Wolff Parkinson White syndrome, but that's conduction coming down this way and going back that way. So there are all sorts of different medicines we can use. Rate control means that we're just going to slow down the problem. And the simplest and most safe medicines are AV node blockers called digoxin, which is from the foxglove. It's been around for a couple of hundred years. Calcium channel blockers like verapamil or diltiazem. Beta blockers. If there's any heart dysfunction, we use metoprolol, bisoprolol, or carvedilol. Those are the 3 that have been shown to help the heart pump better. But if there's no problem with the heart muscle, we can use any other beta blocker like atenolol, propranolol, pindolol, acebutolol. There are all sorts of different ones. If the sinus node is weak, I like to use pindolol because this has what we call intrinsic sympathomimetic activity. So it can actually be a beta blocker, but it doesn't slow the sinus node down like the other ones. So it's fairly complicated. There's all sorts of a potpourri of medicines, but I like verapamil to block the AV node, and it also is good for some of the ventricular arrhythmias. Digoxin is really it doesn't lower the blood pressure. Calcium channel blockers and beta blockers do lower the blood pressure, so if anybody starts with a low blood pressure, it's a little bit tricky. Tachycardia-mediated cardiomyopathy we usually see with atrial flutter or fibrillation or atrial tach. This is where the heart can go fast so much that it depletes the energy stores. And this is a scary situation with these 3 things. So just get in the habit of checking your pulse every once in a while and making sure it's not too fast. If you have any dizziness, for unexplained dizziness, check your pulse. Maybe you're going too fast. By the way, if you're having any dizziness, the quickest and best thing to do is to get down on the floor. Otherwise, you might fall down on the floor and end up with raccoon eyes. So if you're dizzy, the most common thing, especially in a setting like this or church, is what we call vasovagal syncope. The blood vessels dilate inappropriately. The blood comes out of the head and chest. They stand up, say hallelujah, and boom, down they go. Fire and brimstone. Okay, atrial flutter, how does it look? You see, it looks almost like a saw. We call this sawtooth pattern. And from the back of the room, it's going to be hard to see that, but it looks like a saw. If we burn it, boom, it goes back to sinus rhythm. So you see here there are 2 or 3 or 4 atrial beats for every ventricle. Here there's 1 to 1, and they're cured. This is the way it looks inside the heart if we do the procedure. This catheter is coming from the inferior vena cava to the right atrium. This one's coming over here. This is the ablation catheter. It has a bigger tip. This is in the right ventricle. And this is at the bundle of His, which is part of the conduction system. So we actually can record electrical pathways with all these different catheters and determine what's the earliest activation. And then we incorporate it into a 3-dimensional mapping system that I think I'll show you in a minute here. And it's pretty cool. It's almost like playing video games. I was never very good at video games, but I'm getting better at video games because that's what we do during the day job. Anticoagulation is blood thinners. The classic blood thinner is warfarin, and warfarin has been around for 50 years. And the main thing with somebody who has atrial fibrillation is to make sure they're on a blood thinner, because without a blood thinner, the risk of stroke goes up by 5 times versus the standard population. Okay, go ahead.
What do you think about the new one, the Eliquis?
Eliquis, you have to be put there for me. You know, that's my favorite one. I actually speak for Eliquis, and I went through my disclaimer slide because I didn't think I would get that question. But no, Eliquis is called apixaban. It's a factor 10A inhibitor. First of all, the traditional one is warfarin. Warfarin is the only one we can use if somebody's got a mechanical valve. So the newer ones aren't approved. If you've got lone atrial fibrillation, and lone atrial fibrillation can mean atrial fibrillation in the presence of no valve problem. I mean, no mechanical valve. You can still have regurgitation or stenosis, in other words, a blockage or a leak, and you can still use Eliquis. Eliquis is the 3rd NOAC, novel oral anticoagulant, that there is. The first one was dabigatran, called Pradaxa. Pradaxa and Eliquis are the only 2 that have been shown to be superior to warfarin. There's another one called rivaroxaban, or there's another one called edoxaban. And Xarelto is the rivaroxaban. Those are non-inferior to warfarin. But the only 2 that are superior to warfarin are dabigatran, Pradaxa, or apixaban, Eliquis. I love Eliquis. The reason is most people tolerate it beautifully. I put them on it and I don't hear back from them, which is always a good thing. If we put them on Pradaxa, they also did very well, but approximately 20% of people in my experience had GI problems, GI intolerance. So I like Pradaxa, I like Eliquis. Eliquis I like the best just because it doesn't have as many side effects in my experience. In addition, the risk of bleeding is less than warfarin. I personally think that if somebody's doing great on warfarin, it's reasonable to stay on warfarin. If it were me, I would switch to one of the novel oral anticoagulants. Eliquis does not have something to reverse it, though. So if you get into a bleeding problem, you're kind of stuck. You have to wait. But they've had a study called the Aristotle study that looked at 18,000 patients. And it was much superior to warfarin in terms of risk of bleeding, in terms of risk of stroke. And so I really like Eliquis.
I take the half of aspirin, that takes it better than the half of aspirin.
Uh-huh.
Yeah, okay.
So I'm sorry, you said you take half an aspirin?
No, I don't. I said, is that half an aspirin is what they sometimes say.
Okay, so the question is, are you talking about atrial fibrillation?
Yeah.
Okay, so atrial fibrillation, the question was, is aspirin as good as Eliquis? Now that gets us almost to this CHADS2-VASC situation. But the bottom line is the European Society of Cardiology doesn't have aspirin anymore on their guidelines. The American College of Cardiology still has aspirin if you're at low risk. If your CHADS2-VASC score is 0 or 1, where 0, they recommend nothing. For 1, it could be aspirin or oral anticoagulant. Now, CHADS2 VASC means, here are the factors. The C stands for CHF. So if you've got congestive heart failure, if your ejection fraction is low, or if you've got high blood pressure. Age greater than 65 is 1 point. Age greater than 75 is another point. Woman's sex. If you're a female, you're hosed. No, I'm just kidding. But that's actually, it's a risk factor for stroke, is just being a woman, unfortunately. If you've got any type of vascular disease, if you've had a carotid problem, if you've got peripheral vascular disease, if you've had a heart attack, that's another point. Now, diabetes is another point. So if you've got any of those things, you start adding up the score. If you've got more than 2 points, more than 2 of those things. So if you're a woman age 75 and you've got atrial fibrillation, you need to be on a blood thinner or your risk of stroke goes up significantly. The higher the CHADS2 VASC score, the higher your risk of stroke. I don't want to scare anybody, but I want to tell you, if I were having AFib, I would definitely be on a blood thinner, even if I was CHADS2 0. Now, there's an argument. Well, she's a fall risk, doctor. If somebody comes in with raccoon eyes and a face plant, that's when I draw the line. I say, okay, you've proven yourself. That's not good. Because if you're on a blood thinner and you fall and hit your head, you could bleed into the brain. Most people who fall are still not that high of a risk for smacking their head. But if you're smacking your head hard, you could bleed into the brain. So that's the downside of a blood thinner. Or if you have an ulcer, you could bleed. But I've personally never seen anybody die of bleeding. But if you've had a stroke, it's forever. So a stroke is a devastating problem.
What did you say your opinion was on Xarelto?
Okay, what is my opinion on Xarelto was the question. Xarelto is non-inferior to warfarin. So they've done a study called the Rocket that looked, it's I think 16,000 patients. It's a very large study. Xarelto is a good drug. It's not better than warfarin. In my opinion, and the nice thing about Xarelto is you can take it once a day. But if you look, about 70 to 80% of patients are already taking drugs twice a day anyway. So that's not a big deal. Xarelto, the other thing about Xarelto is if you're on Xarelto, make absolutely sure you take it with the meal. Because if you don't, the bioavailability is less than 60% what it is if you're taking it with food. And a lot of times people don't know that. So you got to take it with food if you're on Xarelto.
Does it interfere with K?
It does not interfere with vitamin K. The nice thing about all the NOACs, so the novel oral anticoagulants, is you can have all the green leafy vegetables you want. You don't have to worry about food interactions with any of the new drugs. With warfarin, you really do need to watch the green leafy vegetables. All the vitamin K, 2, 7, 9, and 10 are 4 of the cofactors in the coagulation cascade that are bothered by vitamin K.
What would you recommend for somebody with artificial valve in the heart as well as AFib? What would you recommend?
If you've got an artificial valve in the heart, you've got to be on warfarin. That's if it's a mechanical valve. If you've got a prosthetic valve, meaning either a pig valve or a bovine valve, you don't really need to be anticoagulated, usually. Most of those folks are on like warfarin for a month or 2 and then they're off of it. But if you've got a mechanical valve, you have to be on warfarin. And for a mechanical valve, your INR is higher. It should be probably 2.5 to 3.5, and you also should be on aspirin, probably a baby aspirin. The risk of bleeding doubles if you're on aspirin and a blood thinner. So unless you've got carotid disease or coronary disease, if you've got heart blockages or carotid disease, we like to get people off the aspirin. Now that reminds me, you asked a long time ago about what was the deal with aspirin, and I forgot to address that. There was a study called Averroes that looked at apixaban, Eliquis, versus aspirin. The risk of bleeding with aspirin is 1.3% per year. The risk of bleeding with apixaban is 1.5% per year. So they're not statistically different. But the risk of stroke was much higher on aspirin than it was on Eliquis. And that's my whole point. if I have atrial fibrillation, I am darn sure not going to be taking aspirin just because it is inferior by a huge amount versus one of these novel oral anticoagulants. And the risk of bleeding into the head is no different with aspirin than it is with apixaban.
So, two-part question. When you're talking about the risk with aspirin, you're talking about a full aspirin or an 81 milligram aspirin. And then the other part of my question is, how does Plavix compare with some of these other drugs that you're working on?
So the question is, how does Plavix compare with some of these other drugs? And when we're talking about aspirin, are we talking about baby aspirin 81 milligrams or a full adult aspirin 324 milligrams? That's a great question. From a GI bleeding point of view, the risk of bleeding is higher with a full aspirin 324 than it is with 81 milligrams. And if you're a big person, you probably should be on a full aspirin. If you're a smaller person, 81 milligrams is probably very reasonable. And Plavix is an antiplatelet drug, kind of like aspirin, only it's a little bit more powerful than aspirin. I do not like doing surgery on Plavix like I do. Aspirin doesn't bother me at all. Warfarin doesn't bother me at all. The novel oral anticoagulants, we usually don't even stop most of these blood thinners. But Plavix causes bleeding, and the surgeons hate it. So it does work well, because anytime we have to do open heart surgery and somebody's on Plavix, it's a bloody mess if we can't stop it ahead of time. So it does work. But in terms of preventing AFib, they don't work very well. Plavix and aspirin are good for coronary disease. And if you've had a stent, if you've got a bare metal stent, we can usually get you off the dual antiplatelet, either aspirin and Plavix or aspirin and, I can't remember the name of the other one that they have people on now. But it's usually dual agents if you've got a drug-eluting stent for at least 6 months, if not a year, or if not indefinitely. But the risk of bleeding goes up. So we have to temper the risk of causing a stent problem versus the risk of bleeding, or causing a stroke versus the risk of bleeding.
On your first slide, you had the heart and EKG, and you had a O. What does that stand for?
Oh.
There were different alphabetic numbers there, and down almost a little below the middle line.
It's a Q.
I hate these.
I have no idea. I can't remember what that was.
Right there. What is that?
Oh, Q.
It's a Q.
Q.
Yeah, that's a Q.
No, one up.
That's a Q also.
Yeah, that's a Q also. The Q wave, a Q wave is if you see a Q wave, that usually means they've had a heart attack. If it's a wider Q. But a Q goes down this way. The normal baseline is like this, but a Q wave is down.
What if you had an O there?
Great question. I like this group. Okay, any other questions? Oh, there were about 100 other questions. Okay, go ahead.
When you talk about burning a problem away, you're talking about burning a conductive tissue out.
Yep.
What if you burn out too much?
Whoops. That's why we have pacemakers. No, the question is, what if we burn out too much? And that's a problem. You know, if we burn out too much, usually where we're burning, it's not contractile tissue or it's a fairly isolated spot. If somebody's had a heart attack, for instance, and they've got a reentrant short circuit around that, we like to burn in the scar. Believe it or not, inside the scar is healthy tissue. And where that interface is, sometimes we get a very fast short circuit there. So if we're burning within the scar at healthy tissue, it's not going to cause a problem at all. If we burn out near the AV node or the conduction system, then there's a risk of a pacemaker. And that's one of the reasons I like to use cryo, where we freeze it out instead of burn it out. We don't have cryo yet available in this community, but we're going to get it hopefully soon. If somebody has something we think is very close to the conduction system, I'll take them to Spokane, and we'll do it up there at Sacred Heart.
Well, let me ask a follow-up question. Looking down the road, doing what you do with pacemakers and whatnot, what technology improvements do you see coming your way in the next year or two? What tools?
The question was, what technology, what tools do we get to see within the next year or two? And I'll show you that in a second here. Hopefully we can get to it. And in fact, if we don't, I'll tell you after the talk, okay?
I like the question this man had earlier. What's coming down the pipe?
Okay, let me just see if I can. Okay, so here's what's coming down the pike. So this is what we're doing right now. We actually take what's called a lasso catheter, or now I have, actually this is an older slide. This is a 20-pole circumferential mapping catheter that we put in to reconstruct the left atrial geometry. And we use this as a target when we're burning around this vein. The pulmonary veins, these are the pulmonary veins right here and right here. We're burning around those inside. The balloon, the cryo balloon, is actually, instead of burning point by point with the radio frequency energy, we can take a balloon, a cryo balloon, and shove that up in the pulmonary vein. This is a pulmonary vein, and burn, boom. 4 minutes, we've electrically isolated it. It usually takes about 2 freezes. The definition is negative 80 degrees, and we use about plus 60 degrees centigrade Celsius for these. So it's complete different ends of the spectrum. This is what our three-dimensional mapping system looks like after we've put those circumferential catheters, or I have what's called a penta-array catheter now. It has about, almost 50 electrodes. We put that into each of these veins, and this is actually a reconstruction of what we reconstruct three-dimensionally. And then we don't even have to use X-rays. So we burn. All these red things are burning marks. We burn around each of the veins. This particular person also had to burn horizontally to interrupt anything that was coming down this way. This is another line between the tricuspid valve here and the inferior vein over here. Okay, now here is the world's smallest pacemaker. You ask what's coming? This is a pacemaker that's a leadless pacemaker, and this is here right now. The problem is it only paces a ventricle. We put it through the vein in the leg, and you don't even have a lead in your body, except it's in the ventricle. And it's not going to last quite as long, and it only paces the ventricle. So it's, in my opinion, it's less utility. I wouldn't really put these in yet, but that's what's coming. This is what's here now. There's what's called a Watchman, which is an occlusion device. And somebody who's not a good candidate for a blood thinner, this is the left atrial appendage. It's the ear of the atrium I was talking about. We actually put this thing that then fibroses over, and it prevents clots usually coming from the left atrium here, so that these people don't need to be on a blood thinner like the warfarin or the NOACs. And this is another way to do this. That actually we can go in outside the heart and lasso. It's called a lariat, and that's exactly what we do. When I say we, I don't do this. But this is a lariat that comes right over the appendage, and there's a magnet right here. This is from the left atrium. This is from the outside of the heart, and the appendage is here. We snare it and then cut it off. So it's all sorts of cool stuff that's happening. The end. Any other last questions? Uh-huh. It depends on the ablation. If you've got something that's very close to the junction box, your risk is probably up to 1 in 100 to 1 in 200 chance of a pacemaker. If we do it with radiofrequency energy. With cryo, I've personally never had a problem, but it's about 1 in 200 if you're burning something very close to the AV node. For an AFib ablation, the risk is almost 0. For a flutter ablation, it's probably 1 in 200. It depends on where you are relative to the normal structures. Oh, okay. Well, it's good to be here. Thank you.